cold is one type of upper respiratory tract infection. Upper respiratory tract infections are illnesses caused by an acute infection which involves the upper respiratory tract, including the nose, sinuses, pharynx, or larynx. The common cold and acute bronchitis are similar in symptoms and treatment. Acute bronchitis affects the lower respiratory tract and should be treated like the common cold unless pneumonia is suspected. In this presentation, I'm going to talk about the drugs for the common cold and influenza. You may extrapolate information about the common cold and apply it to acute bronchitis.
Acute rhinitis is one of the most common diseases affecting adults and children. It can impair quality of life and loss of work and school attendance. The medication treatment that will be reviewed is from the American Academy of Otolaryngology, Head, Neck, and Surgery Foundation. These are guidelines for allergic rhinitis from 2015. Some of these charts are small. You do have a copy of the guidelines for better viewing under the required readings. What do you need to know from these charts? You need to know the general comparisons across medication types, including benefits, the names of some of the medications, and side effects. You do not need to know doses. Drug treatment is an addition to avoidance of known allergens or environmental controls, such as removal of pets, the use of air filtration systems, bed covers, that sort of thing. Clinicians should recommend intranasal steroids for patients with a clinical diagnosis of allergic rhinitis, whose symptoms affect their quality of life. Short courses of systemic corticosteroids are often used clinically for patients with severe allergic rhinitis that have not been shown to be superior to intranasal steroids. Note that the names of these corticosteroids are the same as those for asthma inhalers. Intranasal steroids are very effective. With potent anti-inflammatory processes, the intranasal steroids directly modulate the pathophysiology of acute rhinitis. They result in significant reduction in the mediator and cytokine release, along with inhibition in the recruitment of basophils, eosinophils, neutrophils, and mononuclear cells to nasal secretions. In addition, use of these agents in seasonal disease leads to a reduction in inflammatory cells and cytokines within the nasal mucosa and secretions of patients with allergic rhinitis. There are no significant difference between the efficacy of the available agents. Notice one is available over the counter, so getting insurance to pay for these others may be difficult. Some of the prescription formulations are once-a-day application, which is an advantage. If no response is observed after 1 week of treatment, the treatment might be considered ineffective. Along with diminished nasal symptoms, intranasal steroids have a beneficial effect on allergic eye symptoms, including itching, tearing, redness, and puffiness. Intranasal steroids reduce nasal symptoms, including sneezing, itching, rhinorrhea, and congestion in adults and children. By reducing nasal symptoms, intranasal steroids significantly improve the quality of life and sleep of patients with allergic rhinitis. The most common side effects of intranasal steroids are a result of local irritation and include dryness, burning, stinging, blood tinge secretions, and epistaxis. Epistaxis can be minimized with proper intranasal steroid positioning and administration, generally pointed away from the septum within each side of the nose.
Intranasal steroids are superior to oral H1 antihistamines in controlling nasal symptoms. However, clinicians should recommend oral second generation, less sedating antihistamines for patients with acute rhinitis and primary complaints of sneezing and itching. So they have to have the nose symptoms with the sneezing and itching. An oral antihistamine used as a single agent, either intermittently or continuously, may provide adequate relief for many individuals. While they may not be as effective as intranasal steroids, they are adequate for many patients with mild to moderate disease and have the advantage of lower cost, rapid onset of action, and effectiveness for intermittent symptoms. Advantages of oral antihistamines include rapid onset of action, once daily dosing, maintenance of effectiveness with regular use, and the availability of some drugs without a prescription. The second generation antihistamines can be used in the elderly. That's very important. Intranasal antihistamines have a more rapid onset of action than intranasal steroids. One of the benefits of intranasal application is targeted delivery and increased dosage to nasal tissues while limiting systemic effects. For the treatment of nasal symptoms, intranasal antihistamines have shown equality or superiority to oral antihistamines in numerous studies. 2 intranasal antihistamines are currently approved by the US FDA for treatment of allergic rhinitis. Azelastine and olopatadine are both second generation H1 receptor antagonists and have equal efficacy in head-to-head placebo-controlled comparison studies. Again, as I said earlier, intranasal antihistamines also have the advantage of rapid onset of action in the range of 15 to 30 minutes, which is much faster than in the oral route, which has an average onset of about 150 minutes. Due to the rapid onset of action and targeted delivery of intranasal antihistamines, they are especially useful in patients with episodic nasal symptoms or as a pre-treatment prior to nasal allergen exposure. The need for twice daily dosing and the side effects of somnolence and bitter taste, however, may lead healthcare providers and patients to prefer initial treatment with a different class of medication. The most common adverse events related to intranasal antihistamines are bitter taste, epistaxis, headache, somnolence, and nasal burning.
This is a summary of the recommendations for treatment. Note that clinicians should not offer the leukotriene receptor antagonist as primary therapy for allergic rhinitis. In addition, the newest guidelines do not mention cromolyn nasal spray, which is a mast cell stabilizer, as a treatment for allergic rhinitis. It has a limited role. Nasal sprays come in 2 different kinds of containers: pressurized canisters and pump bottles. Here are the steps for using a nasal pressurized canister. In addition to these steps, a pressurized canister should be washed at least once per week. For both types of canisters, aim straight. Point the nozzle of the nasal spray container toward the back of the head. If not sprayed straight, some of the medication will be wasted and may cause more irritation in the nose. Here are the instructions for using a nasal pump bottle. If the pump spray is used correctly, the spray should not drip from the nose or down the back of the throat. For both types of containers, tell the patient that if the nose hurts, if they begin to have nosebleeds, or if the inside of the nose stings, stop using the spray for 1 to 2 days. Sometimes it helps to use an over-the-counter saline nose spray such as Saline X, Ocean Nasal Mist, or Nasal just before the spray of the medication. Now we are switching to treatment of the common cold. Influenza and the common cold are both respiratory illnesses, but they are caused by different viruses. Because these two types of illness have similar symptoms, it can be difficult to tell the difference between them based on symptoms alone. In general, flu is worse than the common cold and symptoms are more severe and intense. My patients usually say that they have never been sicker in their lives. Colds are usually milder than flu. People with colds are more likely to have a runny or stuffy nose. Colds generally do not result in serious health problems such as pneumonia, bacterial infections, or hospitalizations. Flu can have very serious associated complications.
As you all know, the common cold is caused by viruses and antibiotics are not effective. Most patients come into the office wanting an antibiotic. The most common reason is because they've been previously given an antibiotic for an upper respiratory infection. Most patients believe that the antibiotics work because they got better after receiving them. They do not understand that they would have gotten better anyway. I have difficulty determining which patients with significant comorbidities need an antibiotic for a common cold to prevent complications. Most of the patients I see have significant comorbidities. I usually will give antibiotics to anybody with COPD, especially if they have been diagnosed with pneumonia in the past. The increased bronchial secretions from bronchitis are a perfect incubator for bacteria in these patients who have a reduced ability to clear their airways. I silently chuckle when patients tell me about their purulent secretions or nasal secretions and the color of their secretions. This is a common misperception and patients zero right in on it to get the antibiotics that they are requesting. They also know that facial pain is a symptom of bacterial sinusitis and will play that card also. It's surprising to me that countries have antibiotics that are over the counter. Most countries surveyed recently by the World Health Organization have no national strategy to safeguard antibiotics. Globally, the sale of antibiotics over the counter is widespread, and it is rare that countries track resistance to the drug. Kind of unbelievable.
Oral decongestants include pseudoephedrine and phenylephrine. Oral phenylephrine is the most accessible oral decongestant and can be bought easily over the counter. Non-prescription pseudoephedrine must be kept behind the counter in the U.S. to help prevent manufacture of methamphetamines. Recent oral phenylephrine studies found doses as high as 40 milligrams were no more beneficial for nasal congestion than placebo. Common side effects of decongestants include cardiovascular stimulation, hypertension, tachycardia, paradoxical bradycardia, central nervous system stimulation, restlessness, insomnia, and anxiety, and decreased appetite, and urinary retention. Patients should limit the use of over-the-counter oral decongestants to 7 days unless otherwise recommended by a healthcare practitioner. Pseudoephedrine causes a small 1 millimeter of hemoglobin increase in blood pressure for patients with controlled hypertension. Since oral phenylephrine is not well absorbed, it doesn't appear to increase blood pressure at the recommended over-the-counter doses of 10 milligrams. Expect even less effect for non-systemic agents. Most patients with controlled hypertension should be able to safely use oral decongestants for a few days when they have a cold. However, it is still difficult to predict individual patient response, especially for those with erratic or consistently high blood pressure. There are reports of decongestants causing significant harm to hypertensive patients, especially at high doses. Stimulants used for treating attention deficit hyperactivity disorder may increase the cardiovascular side effects of decongestants. Educate patients to report palpitations or tachycardia. Urinary retention associated with decongestants may be exceptionally problematic for patients with BPH. Patients with diabetes are often told to avoid decongestants due to concerns of increased blood glucose, but this risk is not well documented. Suggest diabetic patients continue to monitor their blood sugar levels or blood glucose, report any changes, and avoid any liquid cough and cold formulations containing sugar. Use decongestants cautiously in patients with narrow angle glaucoma to prevent increase in intraocular pressure. Decongestants may exacerbate cardiovascular symptoms of hyperthyroidism. Avoid using pseudoephedrine in patients who are not well controlled. Decongestants may cause or worsen insomnia. To prevent sleeplessness, avoid decongestant use in the evening or at bedtime. Avoid decongestant use in children, especially those less than 2 years of age. There is little efficacy or safety data to support their use in children under 6 years old. Many cough and cold products contain multiple active ingredients, which may lead to accidental overdoses. Decongestants, including phenylephrine and pseudoephedrine, may cause fetal harm during pregnancy, especially during the first trimester. Not enough information is available for intranasal decongestants, but just avoid decongestants overall. Phenylephrine and pseudoephedrine are also excreted into breast milk during lactation and may cause infant irritability. Use of decongestants can also decrease milk supply. Guaifenesin is thought to act as an expectorant by increasing the volume and reducing the viscosity of secretions in the trachea and bronchi. It has been said to aid in the flow of respiratory tract secretions, allowing ciliary movement to carry the loosened secretions upward towards the pharynx. Guaifenesin, however, is unlikely to be an effective expectorant or mucolytic, as there's not much evidence that it works. Side effects include drowsiness, headache, dizziness, and GI upset. It's tempting to recommend an over-the-counter product with dextromethorphan and or guaifenesin in it. Dextromethorphan suppresses the cough in the medulla. You'll see it listed as DM on the bottle or package, but there's not much evidence that it works. Instead, advise adults to try an oral decongestant and a first-generation antihistamine. These help reduce the postnasal drip that can trigger coughs. Or try naproxen or another NSAID. These might reduce cough frequency by decreasing inflammation and help other cold symptoms on top of it. Benzonatate is a prescription non-narcotic cough medication that numbs the airways, the alveoli in the lungs, and the pleura. These are also called Tessalon pearls. But save prescription cough meds as a last resort. There's not much evidence that benzonatate helps. Opioids don't have much evidence of benefit and can be risky. Save codeine or hydrocodone for when other options aren't enough. But avoid codeine during pregnancy or breastfeeding. It's linked to malformations and can cause opioid toxicity in some breastfed infants. There still isn't good evidence for or against using over-the-counter or prescription medications for acute cough due to a cold. But patients often want to take something. Continue to suggest trying non-drug options first, fluids, cool mist humidifiers, those sorts of things. Suggest plain honey, up to 2 teaspoons at bedtime or as needed. There's some evidence it reduces cough in kids, and it may be worth a try in adults. Focus on safety. Weed out products some patients should avoid. Avoid dextromethorphan if patients are on an MAOI inhibitor, and be cautious about using it with serotonergic meds such as SSRI, tramadol, those things, especially patients on multiple serotonergic drugs or high doses. There are no good data that antihistamines or decongestants reduce cough, but they're often in combo over-the-counter products. Consider anticholinergic effects with diphenhydramine, etc. Short-term pseudoephedrine is often okay in controlled hypertension, but try to avoid if the blood pressure is uncontrolled. Menthol or camphor rubs, Vicks, are okay for adults. Save prescription cough medicines as a last resort. There's not much evidence that any of them work. Avoid corticosteroids. They don't seem to decrease cough duration, and don't give albuterol unless the patient also has bronchospasm. Now we will talk about influenza. Most people who get the flu have self-limiting symptoms, fever, cough, muscle aches, for about 7 to 10 days. Treatment generally includes rest and supportive measures. But some patients have influenza infections that are more serious. There are an estimated 310,000 hospitalizations and up to 56,000 deaths in the U.S. each year due to influenza. Antivirals are generally not recommended for prevention of influenza if more than 48 hours have passed since exposure. These are the indications for preventative antivirals after exposure to an infectious person for patients at high risk of complications from influenza. These criteria include: it is within 2 weeks of receiving an influenza vaccine. There was a poor response to vaccination is expected due to severe immunodeficiencies. If there are contradictions for vaccination. If circulating strains are not covered by the year's current influenza vaccine. Patients at high risk for complications from influenza include pregnant women. That's why they all get a flu shot. Those with chronic conditions such as cardiac, pulmonary disorder, diabetes, cancer, renal disease, all of these. Residents of long-term care facilities, under 5 years of age, 65 years of age and older, and indigenous persons. As you can see, this covers just about everybody that we see in practice.
Okay, drugs for prevention of influenza should begin immediately after exposure and subsequent vaccination. The treatment should last for approximately 2 weeks until the vaccination takes effect. Now, the two drugs are oseltamivir, which is Tamiflu, and post-marketing reports of serious skin reactions like Stevens-Johnson syndrome and neuropsychiatric events, hallucinations, deliriums, and abnormal behavior have been reported. Most adverse reactions are nausea and vomiting. It can be taken with or without food, but taking with food may increase tolerability. And it's not recommended for patients with a creatinine clearance less than 10 milliliters per minute who are not on dialysis. The duration for Tamiflu should be at least 10 days or 14 days if the index case is a child or an elderly person. And you can give up to 6 weeks for community outbreaks and up to 12 weeks for immunocompromised patients. Now, zanamivir is Relenza, and it should be avoided in prophylaxis for patients with pulmonary disease, so if they have asthma or COPD, and it's due to the lack of data and risk for bronchospasm. And allergic reactions with oropharyngeal or facial edema have occurred. It's contraindicated in milk protein allergy, and there's unknown efficacy for long-term care residents and immunocompromised residents.
Okay, now this is for influenza treatment. Don't feel compelled to use antivirals to treat flu in most otherwise healthy patients. Stick with rest, fluids, analgesics, that sort of thing. Antiviral therapy has been shown to shorten the illness by about 1 day. Here's a list of people who should be treated. These are children less than 2, adults 65 and older, persons with chronic conditions, and it's, one of those big long laundry lists of chronic conditions. There's multiple ones here. I'm not going to read them all. But between the list of chronic conditions and the other criteria, there are not many that should not be treated. In these high-risk patients, antivirals may reduce complications. So like it may reduce otitis media in children, pneumonia, respiratory failure in adults, decrease mortality in hospitalized patients, and decrease hospital stays in children. It's okay to treat based just on symptoms of influenza. Keep in mind that false negatives are common with rapid antigen tests. Oseltamivir only reduces flu symptoms by about a day and only if started within 48 hours of symptoms. Plus, it causes nausea and vomiting in about 1 of 20 patients. And even generics cost about $100 a day. Influenza, or the zanamivir inhaler, costs about $60, but it's 2 puffs BID. It's cumbersome to assemble and use and should be avoided in lung disease, milk protein allergy, or under the age of 7. If you're going to start it as soon as possible, ideally within 48 hours of symptom onset. But it's okay to start as late as 4 or 5 days after onset if they're severely ill or hospitalized.
Baloxavir, which is Xofluza, is generally well tolerated. This is my favorite one because it's a single oral dose. The most common side effect is diarrhea, and it appears to have less nausea and vomiting than Tamiflu. The efficacy appears similar to a 5-day course of Tamiflu in otherwise healthy patients who are 12 to 64 years of age with acute uncomplicated influenza. It's still being investigated for possible resistance, but baloxavir may have greater reduction in virus levels and respiratory secretions at 24 hours and a shorter duration of virus detection compared to Tamiflu. It's not recommended for pregnant women, breastfeeding mothers, outpatients with complicated or progressive illness, or hospitalized patients because there's no information about the use of baloxavir in these patients. The perimivir is IV and it's not used in primary care, so you don't really need to know that medication.
This is the end of this presentation. Thank you for your time and attention, and stay healthy.